You've been referred for an ablation procedure for a condition called ventricular ectopy. In order to understand more about this ablation procedure, we have to understand how the normal heart beats. Your heart is made of 4 chambers, 1, 2, 3, 4. And electricity moves around the heart to allow the heart to beat. Electricity starts off at the top of the heart over here, comes down to a structure in the middle of the heart as such, before coming down to the bottom chambers like this. Now this is normal. Ectopic beats coming from the ventricles originate anywhere within these bottom chambers, or in addition to tracts that exit the bottom chambers either towards the lungs or towards the rest of your body. This is the right side of the heart and this is the left side of the heart. Now, an ectopic is defined as an extra focus that allows the heart to beat. And it can come from any of these locations. By far, the most common location are these tracts, known as the outflow tract. An area within these outflow tracts can fire off independently of these normal electrical circuits within the heart. And as a consequence, when that happens, signals come to the heart in this direction before these signals come down, causing the heart to beat prematurely, and can manifest with the symptoms of a skipped beat, a missed beat, a jumping sensation, or a feeling of general uncomfort and discomfort. Now, in all of us, we are experiencing firing from the bottom chambers from time to time. But in certain patients, i.e. those who have at least this behaviour more than 10% out of 24 hours in the day, we might consider doing something more for it, especially if this is a cause of symptoms or as a cause for the pumping chambers of the heart to become weaker. In some patients, we can trial them on medicines in order to try to suppress these foci from firing. Or alternatively, we can recommend ablation. Ablation is a fancy word for burning. In simplicity, it involves identifying precisely where these firings are coming from, wherever they may be, bringing a catheter with the ability to identify its focus and burning it away. A successful ablation procedure can cure a patient of this problem in around 90% of the occasion, for them to completely stop all medicines and for this not to come back. So how do we do it? Well, in order to get to the heart, we have to get access to the heart from the groins. Here is your heart, and your heart is connected via a series of arteries and veins. For this procedure, our veins connect to the right of the heart, and our arteries connect to the left of the heart. If we believe the foci is on the right of the heart, we will get access to the veins first. That involves using some local anaesthetic and implanting a small tube into the vein, which allows us to bring our equipment up to your heart as such. We use a combination of X-ray, the electrical signals within the heart, and often some complex and clever computer software to try to pinpoint the location of these signals. Once we've honed in on the precise location of the signal, we can then deliver the ablation. If alternatively this is coming from the left side of the heart, we may go through the arteries in order to come to reach the area, or sometimes we actually will make a small hole in the top of the heart to allow us to go from the right to the left in order to access the foci of where this may be. What to expect? Before the procedure, your doctor will ask you to stop any medicines that you may have been taking that may be suppressing these extra beats for at least 5 days. If you present on the day of your procedure and we cannot see any of these extra beats, no matter how frequent and how symptomatic you may be, we have no target to identify and therefore cannot proceed with the ablation procedure. We would ask that you have nothing to eat from midnight and a sip of water early morning, but please follow local hospital policy. If you are on any blood thinning medicines, we would recommend cessation of this for at least 2 to 5 days following local policy. The procedure is performed in the cardiac catheterization laboratory by electrical heart doctors. You will meet the team as well as a nurse, radiographer and physiologist. You will lie on a table which will allow us to visualize the interior of your heart under X-ray as well as the electrical signals within the heart as well. You will also likely see a 3-dimensional computer model of your heart being created to allow us to refine the precise location of this extra focus. As mentioned at the beginning, it is imperative that we are able to see that you are firing from these extra foci, because if not, we will then have nothing to target. In order to bring these about, your doctor may attempt to try and stress your body, whether this be emotionally, mentally, or pharmacologically, by giving you a series of either mental arrhythmic exercises or adrenaline mimicking medication. Assuming that we are seeing plenty of these extra foci beating, we will then proceed to getting access to the heart and performing the procedure, which is done under conscious sedation, not general anesthesia. We strongly avoid general anesthesia as this can in itself inadvertently suppress these extra beats from firing. If the procedure itself is uncomfortable, we can give you plenty of pain relief as much as tolerated. But this must be limited by the risk of inadvertently suppressing these extra beats from firing. Once we've honed in on the site that we believe is causative, we will deliver the treatment, and in some patients this can be sore. We hope that with ablation at this critical site, either one ablation lesion alone or a cluster of ablation lesions to eliminate the muscle tissue around this area, can prove successful. Once the procedure is completed, you will return to the nursing bay where the nursing staff will follow a set protocol of recovery. You should aim to be discharged on the same day of the procedure with a plan for follow-up in your cardiology clinic thereafter. What to expect after the procedure? Your groin may be sore for a couple of days and you may have a small bruise. If you notice any significant bleeding or any significant discomfort, please seek help from the centre performing your procedure. Sometimes the heart muscle can be sore having delivered this treatment because the skin surrounding the heart has been inflamed. Now we do this procedure very frequently and it's generally very safe. There are risks, they're small but they exist. We quote around a 2% risk of bleeding complication down at the groin. That would need to either have a blood transfusion or surgery to fix any vascular problem. Up inside the heart, the risk of complication is 1% or less. That includes causing a tear in the wall of the heart, causing blood to leak around the heart into a sac. that would require a drain to take that blood away, or rarely heart surgery. There is a risk of damaging structures within the heart, the most critical being the natural gatekeeper of the heart, which lives up here. If this is inadvertently damaged from any extra beats which are closely located around this site, then one would need to have an artificial pacemaker fitted for the rest of their life. The risk of this is up to 1%. When we're delivering treatment to the bottom chambers of the heart, there's a risk of inadvertent damage to the heart arteries. The risk of this is around up to 1% and could result in heart attack. The risk of stroke or life-threatening complication is around the realm of 1 in 500 to 1 in 1,000. If there are any further questions that you may have, please seek further advice from your physician or the Arrhythmia Alliance.